you can use whatever browser you want to search on and find stuff about insomnia. And there's a whole industry around this that will sell you weighted blankets, herbs, exercise, different things to try to cure your insomnia. Most people have gone through all that. And so they sort of arrive at your doorstep feeling like, I've tried everything. What I need a patient to be able to do is sort of relinquish that belief that they've done it all, because they usually haven't.
This is Sick Health with Kevin Ban, MD. Our show helps you navigate our confusing healthcare system so you can take control of your own health. We've got a really great show for you today. My friend John Cronin is back to talk more about sleep. John trained at Harvard. He subsequently was the director of the Sleep Center out in Scripps in San Diego, and now works on sleep innovations for all people. Now, today we went really deep into sleepwalking, sleep eating, and insomnia. Now, before we get started, please like and subscribe. It is the best way to support the show. John, great to have you back on the show. We got some really good feedback about the first session that we did. I had a bunch of people asking me to go deeper. And so you have graciously agreed to come back. But before we do any of it, we thought we would start with two truths and a lie. So John, are you ready?
As ready as I'll ever be, Kevin. Hit me.
First one. When I was 10 years old, I went away on vacation to Hershey Park, where they have like rides and all that type of stuff. And I woke up in the middle of the night, sitting by the pool in my underwear, and couldn't find my way back to my room. Number one.
Okay.
Number two, I was in middle school. I don't exactly know when, I think 7th grade. And my grandmother, Florence, wonderful woman, and more importantly, one of the greatest cream puff chefs ever, had made a bunch of cream puffs for Thanksgiving. And I got up in the middle of the night, ate all of the cream puffs, did not know I did that, went back to bed, and the next morning totally denied it because I had zero recollection. Number two. Number three. I was in college and painting houses during the summer to make money. And quite honestly, back in the day, I used to sleep naked. And I, naked, crawled out my window onto the garage, the roof of the garage, and was painting the side of the house naked. When my mother, knowing I'm a sleepwalker, came to the window and then cautiously got me back inside before I fell. Number three.
Those are my three options.
Yes, sir.
There's a lot to unpack there, Kevin Ban.
There's lots of pathology.
Yeah,
John.
there
You
really
are not
is.
a psychiatrist, sleep specialist.
Knowing what I know, I'm going to say the lie was the third option, the out of the window naked painting session.
Okay, that happened when I was in college. And you would think that that experience of being on the roof naked painting, or at least simulating painting, would have stopped me from sleeping naked, but it actually never did. Well, no, it did. It has, but not immediately. Number two, I never ate any cream puffs. True about my grandmother. She was the greatest. She was a very good baker. Good cook, great baker. So number two was actually the lie.
Oh, I can't believe it. I don't remember that story about your naked painting. And thanks for sharing.
I thought for sure that you would have known that one. That's why I kept it for last.
No, they were all so elaborate. It's just really impressive. Great line, Kevin. Nice work.
Well, thank you. All right, so let's get into this. So the reason we decided to do this is because of the concept of sleepwalking. And that's something that I've always found interesting. I was a very hardcore sleepwalker, sleep talker in the early part of my life. Interestingly, I don't do it anymore. So let's get into sleepwalking. What drives sleepwalking? Why do we sleepwalk?
The real answer is no one knows really why, but what sleepwalking is and what it represents is behaviors that you typically associate with being awake. But when you look at the brain activity, a person is asleep. So In a perfect world, you have these distinct episodes of you're either awake or you're asleep, and sleepwalking occurs in that intersection. And typically, it happens when you awaken out of a very deep stage of sleep called slow wave sleep. And it's a stage of sleep that kids get a tremendous amount of. Unfortunately, as adults, we get a little less. So your sleep doesn't get better and deeper necessarily as you get older. But in a youthful state, you have that deep, deep slow wave sleep, and you can be awakened out of that to do something like go paint your roof or eat cream puffs or whatever it is. But it's really predicated on that stage of sleep that you're waking up out of.
I'm going to slow you down there a second and just remind people, and it actually helps remind me too, about the stages of sleep.
You typically think of a progression through stages of sleep, 1, 2, and 3. And those stages are associated with increasing depth of sleep. And that slow wave sleep is that third stage. And then you have this special stage of sleep, this fourth stage called REM sleep, which just has different physiology. And so as you measure sleep, you can see things like muscle tone goes way down. You get these rapid eye movements that your eyes sort of zigzag back and forth, so to speak. So those are the 4 stages of sleep. And we know this because we basically, over the years, we've measured sleep with brainwave activity to be able to describe it. And so we're describing that brain activity in those stages of sleep. I will say, though, that there's a little bit of a misconception there because people like to talk about light sleep and deep sleep as if light sleep is bad and deep sleep is good. But really, we don't know. So the brain has this process of sleep, and we're just recording it. And we describe some of these stages as light sleep, but that doesn't mean it's bad sleep. It's actually normal, natural sleep, and you have to have it. You can't just preferentially get all deep sleep. It's just not possible.
Getting back to sleepwalking, you said that it happens really in the deepest part of sleep. I think you said stage 3. So before we go into REM. Now, what causes it? Like, what are the things that happen in 3, or what can bring on such a deep sleep that you end up sleepwalking, as I used to do?
Well, remember that deep sleep is normal, right? But there are situations where you can have on any given night more deep sleep. And typically it revolves around what you did the nights before. So if you were sleep deprived, your brain sort of is trying to recapture this really deep sleep in a way that you'll get more of it on a given night. You're more likely to be exposed to the conditions that would lead to sleepwalking. And what wakes you up to sleep? It could be, a bump in the other room. It could be a noise on the street, something that just kind of triggers you out of sleep partially during that deep stage of sleep. So then you can go do something. We'll just call it paint the wall, right? So you can sort of trigger it. Now, the other thing that we know is that kids are usually much more prone to sleepwalking than adults. So that is a very normal experience in childhood, but typically it extinguishes and just goes away. But in some people, it doesn't. And you might be one of those people, Kevin.
Well, I'll tell you, what this makes me think of? So sleep deprivation, to a certain extent, if you have several nights of not getting adequate sleep, is a setup. And what I thought of immediately when you mentioned that is an experience I had when I was in medical school. 3rd year, I was doing a rotation in transplant surgery, which is chaotic because, you're constantly working. You don't know when you're going to have to go and harvest organs, and then, whether or not you're going to be operating. And so I was in the hospital for essentially 3 days. And on my way home, I made a really foolish driving error, which was ridiculous. And I get T-boned by another driver who, when I got out of the car, I was pretty shaken by the whole experience. Still in my scrubs, the police were there, and he very quickly got a sense for what was going on. And he decided not to press charges or take it any further because he understood that I was a medical student who essentially hadn't slept. But it's fascinating to me that we, the ones now who talk so much about sleep in our own lives, actually, our own professional lives, don't really advocate for sleep.
Yeah, and it is a challenge, right? The culture that you came up through within medicine, which should really be the champion of sleep, actually turns out to be maybe one of the biggest abusers of normal sleep for a second purpose that is important, which is taking care of patients and, the rigor that's involved in that discipline. And it can go from funny anecdote, because I think I shared with you once that I similarly was post call, right? I'd worked a 36-hour shift and I thought I'd grab a bite to eat on the way home. And, I went to Taco Bell specifically. I remember it. And I fell asleep in the drive-thru only to have, a bunch of irate, hungry customers behind me honking at me to move forward. And, it was a funny anecdote and I've remembered that. But it quickly can switch to tragedy. There's a specific tree in Boston along the Jamaican Way Parkway that is notoriously known, and numerous residents have crashed into that tree over decades of training. Part of medical training can be abusive when it comes to sleep loss, and it can have real consequences beyond just, humorous anecdotes.
And where does this culture come from? Like, why do we have this embedded culture that, I'll sleep when I'm dead type of thing?
The whole medical education program is based on a series of progressive responsibilities. So you go through these numerous years of training, and each year you get a little bit more responsibility. And so the term that we use for that group of trainees is house staff, because they used to live in the hospital while they received their training, totally dedicated to their craft. And it just so happens that the main architect of that system, Dr. Halstead at Johns Hopkins, who is a legendary physician in our field and really the architect of this program, he himself sort of set the standards for this. And during his training and his research career, he actually developed an addiction to cocaine. So here you have the main architect who promoted this system of extreme work hours and extreme dedication to this field, who he himself was taking, artificial stimulants to keep that type of metric going and that pace going.
This is a culture we need to change, but I don't think people want us to rant forever on this. So let's get into insomnia. And you have 2 truths and 1 lie before we dive deep here into insomnia.
Yes. Well, I'm not going to divulge any personal tales like you did, Kevin, I don't think. But are you ready?
Ready to go.
Okay. Number 1. Sexsomnia is an actual sleep diagnosis. Number 2.
Okay. Sexsomnia. That would be having sex when you're asleep.
Yes. It could be a form of sleepwalking, potentially.
Okay.
Sleep sexing.
Okay.
Number 2. Dolphins have the capacity to sleep with one hemisphere of their brain at a time.
Okay.
So they take one side of their brain offline and they're awake with the other side so they can still swim. And then they alternate.
Yes. Okay. I feel like Darwin would be in favor of that. Okay.
And then number 3, there are a group of monks in Tibet that have learned to meditate in a way that allows them to actually bank sleep for future purposes. So if they know that, for instance, they're going to have a prolonged period of being awake, they can actually sleep 12 to 14 hours, even more, in an effort to sort of preempt that sleep loss that they'll get.
Okay. Because I paid attention to the first episode where you said it was not possible to bank sleep. So I'm going to say that is not true, meaning that sexsomnia, which I want to be true, is true. And dolphins sleeping with half of their brain, which feels like, yeah. So I will go with the lie is banking sleep.
Well, Kevin, you paid attention. You actually got it right, which is pretty impressive. I like your analytic method. And, I'm glad that I was consistent because I forgot about that earlier point that we made. So I'm glad you were really dutiful.
Johnny, I'm paying attention. You know this, right? Okay. Insomnia. Ready to dive deep here, Johnny?
Let's do it.
It seems to me, at least anecdotally, that this is a huge problem.
I think by any measure, it's really high, right? The extent is high. It depends on how you define insomnia. There's probably no adult in this world that hasn't had at least one night of bad sleep, but that doesn't really constitute insomnia. Insomnia is really sort of a longer term issue, maybe multiple nights at best. At worst, it could be years and years in the making and sustained insomnia. But if you look at polls from like the National Sleep Foundation and others, you're looking at chronic insomnia rates of 30% of the population. Is probably a little bit less in overall chronic nature of the insomnia, but it's very, very common. Insomnia is in itself, it's not really a sleep disorder. It's an alertness disorder. And the brain is comprised of two sort of complementary systems, one that keeps you awake and alert and active and smart and everything you want to be as a human. And then the other is to put you to sleep. And so these things are in balance in most of us, almost like a switch mechanism. You go to sleep at night, you wake up during the day, and it's pretty preserved. But in people with insomnia, really, they have an overactive alertness mechanism so that they become unbalanced. And so the problem here is that imbalance is really reflective of that brain 24 hours a day. So if we measure things like stress hormones in the bloodstream in people with insomnia, those are elevated 24 hours a day, not just at nighttime. And so it really kind of gives you this idea that this being, this human, has experienced this chronic this chronic disorder where they're essentially unable to get to sleep. And it's because their brain's overactive. And so they've lost the ability to balance those systems.
And how much of that is genetic? How often are we born to be insomniacs? Versus, is there some learned type of mechanism? Meaning, I've chosen a career, for example, that is exceptionally stressful. I am constantly being stimulated and subsequently have a hard time sort of cooling it down. In the last episode, you talked about landing the jumbo jet, the 747. Right. And so I just have a really hard time doing that because I'm always on the go.
It's really both. It's nature and nurture, unfortunately. And it's really difficult to tease that out for individual patients. Sometimes you just can tell from their story that they didn't sleep well. Their mother complained about them as an infant, a toddler, a teenager, all the way to adulthood. But other people, it just happens to them, right? And how does it happen? Well, usually it's precipitated by some stressor. Sometimes it's obvious, a sick family member, a relationship that went awry, a work environment that's toxic, or just an overload. Doesn't even have to be negative. And these things kind of trigger these sleepless nights. And then those sleepless nights can start to build on each other. And then what can really happen to people is the insomnia itself takes on its own life as a stressor, right? The more I want to sleep, the less I can.
And we contribute to that stress because we do episodes about how important it is to sleep, right?
Yeah, I mean, you've touched on a real sensitivity, Mike, because ultimately sleep is having its day, which it should, right? We're really seeing it as a pillar of health, and we're having all these scientific discoveries about how important it is and essential to our well-being. That's 95% of the message that's out there, right? And so if you're an insomniac and you're chronically not sleeping, it just adds to your misery, right?
The point of suffering in silence, it can be really devastating to a person. It can create a tremendous amount of anxiety, or is it the anxiety that's causing the insomnia? And yet you're suffering to a certain extent alone.
Yeah. I mean, on a certain level, it's like living your own little private hell. I think most people could say, yeah, I understand what a bad night of sleep is. And I can sympathize with you. I can empathize with you, what you're going through. But if you walk around during the day and you see people, you don't know how they feel, how they slept last night. So it can be, I think, very isolating for people because they're suffering something that doesn't really have an outward appearance. You can't just see that person and go, oh boy, they're really in a tough way, right? And so I think emotionally that tends to dislocate people from their family, their friends, simply because people don't understand what they're going through.
I would say is listening to you is look, there can be a genetic component, but often it's a nature type of thing. And that for me is hopeful because if it is a nature type of thing, well, then I can change, the context of my nature such that it's possible for me to be able to create an environment where I can sleep better. How often do people actually make it to a sleep specialist? What are those things that, would prompt someone to say, okay, enough is enough. Now it's time for me to go and be seen by a sleep specialist.
Healthcare is pretty tough, right? So we've all had those symptoms where, for instance, you have a cold and you call your doctor and you say, well, can I get in to see my doctor for my cold? And it's going to be 10 days or something like that. And you just get better. So if you just look in the general population, the numbers are probably very, very high. But to actually make it to a sleep doctor, you have to jump through a lot of hoops to get there, right? You have to typically go to your primary care doctor. They might take a couple stabs at the insomnia. Then if that's not working, they might refer you on to a sleep center, or you find that care yourself. But then there's usually wait. So you're typically going to see in the sleep center people with more intractable, longer term insomnia because they just haven't found solutions, and so they're motivated to keep charging on to try to get to that solution. But for most of us, we'd probably fall off before we even get there, and either sort of suffer in silence, or maybe it's a transient insomnia that just goes away on its own. The challenge is really when it comes to what do you do about it, right? And so I think some of the challenges exist around medications, other therapies, because any intervention really has a benefit and a potential risk, particularly when you're talking about medications. And so the field is still trying to sort that out, right? When do we actually treat people for these conditions?
What are the most common things that cause insomnia?
Let's just talk about the environment, right? Kind of the milieu of your day-to-day activity. Is it stressful? What type of pressures do you have on you from a social standpoint, family, economics, conflict? You can then start to bring that towards the person and say, what is that person experiencing? And you think about things like other medical conditions, chronic illnesses, pain, discomfort, medical illnesses such as thyroid disease. These types of things can just make your own biology a little less capable of sleeping well. And those need to be dealt with. They're sort of causing or playing a role in the insomnia. Probably having a medical issue is a stress in itself. So almost any medical disease could lead to some insomnia, but classically you think about a few. One would be really mood disturbances, depression, anxiety. Very hard to have those conditions and not have some degree of insomnia as part of the overall issue that you're having. Then you think about chronic issues like heart disease, congestive heart failure, lung disease, asthma, things where you can't breathe well at night. These are things that people deal with, and it just disrupts their sleep. Not to mention the medications that they have to take for those conditions that also can disturb sleep.
In talking about mood disorders, that's tricky, right? So you have a patient now who's you're evaluating, and you have to sort of discern between what may actually be a mood disorder and is not technically a sleep disorder. So how did you approach that?
Typically, with any patient, you would really be open about that exploration, right? And the description I would always use is we have these Venn diagrams, right? We have an overlapping circle of insomnia and an overlapping circle of mood disturbance, and they cross. And it's really difficult to tease those apart. And so it's really trying to understand and weigh what are their symptoms and how does that present within the context of their mood disturbance to understand, is the insomnia a result of the mood disturbance, or is the insomnia a cause of the mood disturbance? And as we've talked about previously, when you're not sleeping well, you're anxious, you have more negative thoughts, classic symptoms of depression or anxiety. Ultimately, many times what you have to do is sort of tackle both head on.
When I say medications, what are the ones that sort of immediately pop into your mind that cause insomnia?
Yeah, well, unfortunately, if it were so simple, you could just treat a mood disturbance or insomnia. The challenge is that a lot of the medications that are used to treat depression and or anxiety to a certain extent, a lot of those also can cause fragmented sleep. So typically you think of SSRIs, the serotonin reuptake inhibitors. Classical ones would be Prozac, Paxil, these other drugs. They can actually, by design, affect neurotransmitters in the brain to improve depression. And that's been a long story that's proven out for many people very beneficially. But those same neurotransmitters govern those systems that put you asleep and keep you awake. And so many times people experience more fragmented sleep or less restorative sleep because they're on those medicines for depression. So it's a complex story, and it takes really diving in and understanding what are your options if you're going to be treating with medications. You're going to be treating your depression. There are many different options that can be used, and sometimes patients have to go through different ones before they really understand that. But apart from the SSRIs and those medicines, typically you think about medicines like corticosteroids, which are chronically used in things like asthma, rheumatoid arthritis, chronic pain conditions. So in that intersection, you have chronic pain plus a corticosteroid. Sleep's going to be disrupted for a lot of those people. Cardiac medications like beta blockers that cross into the brain more so than other medicines, that can affect sleep. So, there's pretty much numerous opportunities for your sleep to be disrupted by medications. The challenge is really understanding what's the risk and the benefit of them.
And I think it's really important for people to recognize that connection, that oftentimes the mood disorder that has you on that antidepressive medication may also be contributing to your insomnia. Restless leg syndrome. Okay, I mention it because a good buddy of mine, Dave, suffers from restless leg. If I understand it correctly, it's not every night, but it happens fairly often. And when it does, it's really, really disturbing. So tell me more about restless leg.
Well, first, I think we got to talk about the name, right? Restless leg syndrome. I honestly think I've seen probably 2 or 3 comedians talk about this like it's a joke. What 10-year-old doesn't have restless leg syndrome? But it really does a disservice to the condition because, like you said, it can be super devastating for people. But it really ranges from very mild intermittent things to every night. But essentially, a person experiences this urge to move that they can't satisfy without moving. And so for some reason, and it's like a cruel joke, it comes particularly evident at night when you're trying to go to sleep. That has to do with the fact that you're inactive. It has to do with circadian rhythms of sleep. But basically, right when you want to get to sleep, your body is sending you signals that you have to resolve by movement. And so it can be quite devastating to sleep. Restless legs can be precipitated by things like sleep deprivation. You had a bad night of sleep, and then the next night's a little bit worse. It can be medications. And again, here, a lot of the culprits are the mood disturbance drugs like Prozac and other SSRIs. It can be caused by lack of exercise or too much exercise. And so people might, like your friend, might have a variable experience with this. But in the extreme cases, it can be unrelenting and really produce a lot of misery to patients. It's really sort of a pain syndrome for them. It can really fundamentally just devastate their sleep.
And what do you do in this situation? Is this amenable to medications, or what's the best treatment?
Well, it's like a lot of things. You want to tease out what is there genetically, let's say, that this person just has. You want to look for additional causes that you can try to eliminate, whether it's within the environment or other medications. And then it just really lends itself to a good discussion with the patient as to the risks and benefits of different drugs. Because there are different drugs that can treat this, usually effectively, but sometimes not perfectly. And so just trying to work with a provider to get that right combination that works for you can really be key. I'll also mention that some people have this because of iron deficiency. So we oftentimes see it in women who are still menstruating because it's very common to be iron deficient. And in those cases, sometimes simply supplementing the iron can start to resolve it as well. So you don't need to suffer needlessly. And it's much more important than just this title of restless legs for a lot of patients.
Actually, that's probably the biggest takeaway, which is like, this is no joke. And somehow the name suggests that it might be helpful. Okay, look, John, what I want to do as we kind of come into the final turn here is talk about how you approach patients when they end up, when they show up in your office for the first time, and more equally important, how do you treat insomnia? But before we get into that, Here's a word from our sponsor. C2 Sense is doing important work with its Halo platform, applying technological advances in chemistry, machine vision, and material science to provide both patients and providers with laboratory-level accuracy at low cost when they need it. The pandemic reinforced the importance of being able to test in the privacy of your own home. C2 Sense's goal is to use their patented technology to ensure the same quality of testing you would find in your doctor's office in the comfort of your own home. So if you're suffering from upper respiratory symptoms like cough, sore throat, nasal congestion, or a headache, keep your eyes out for C2 Sense as they're developing tests targeting upper respiratory conditions such as COVID and flu. If you want to learn more, see what they're up to at haloreader.com. Okay, John, so take us through it. Now you have a patient likely who's been around the block a couple of times. They've tried all of the easy stuff. They may have even spoken to their PCP, and now they end up in your office. What's your approach?
By the time they get to my office, they've suffered for a while, right? So usually there's a long history. And first and foremost, you just got to hear the history. You got to understand what are the unique circumstances that this patient is experiencing that have led them into your office. And really, it's rolling up your sleeves. And sometimes that history starts 20, 30 years before that, in childhood or even before. Sometimes it's, self-evident and it's clearly triggered by an event. And sometimes it's just a mystery. And you're just left with, I don't sleep well. But almost always with that comes with it a response from the person who's lived with this reality. And so you really need to understand kind of what they've tried to do to conquer their insomnia, because some of those things can be helpful, but some of those things are actually the problem. I think it's a good thing that people have access to a lot of medical information. And so you can use whatever browser you want to search on and find stuff about insomnia. But typically there's a whole industry around this that will sell you weighted blankets, herbs, exercise, different things to try to cure your insomnia. But the reality is that most people have gone through all that. And so they've sort of arrive at your doorstep feeling like, I've tried everything. And that in itself becomes a challenge for most providers and patients to kind of find that common ground, because what I need a patient to be able to do is sort of relinquish that belief that they've done it all, because they usually haven't. In fact, what they've done is they've built up a whole house of cards around their sleep that they think that, is the key to what they're doing. But it's really the key to perpetuating their insomnia.
Now, we've got to talk medications. I want to go deeper into this concept because I know that for the most part, you're not a huge fan of medications. And you would prefer to approach this in a different way. I feel like all the time people are like, well, I saw my PCP and they're just not giving me that special super secret drug that I know the sleep specialist is going to write down on the back of a piece of paper so that I can get this special medication. So how do you think about meds and what role do they play?
It's a very complicated landscape right now. And this is somewhat actually informed by what has happened with the opioid story in the last decade or so, right? This emergence of this drug class that is used widely, and then suddenly we appreciate that, wow, maybe this isn't really good for patients. The FDA has a way to set certain controlled levels of different drugs. And so controlled drugs require greater scrutiny in terms of the prescription and the maintenance of it. Sleeping pills in some way have been wrapped up in all that, in the sense that, hey, are these really the best things for patients, right? And I think the truth is that they can be great things for the right patient, but in terms of an expedient approach to treating insomnia, they're usually not for everyone. Because with every drug, you have an effect, typically trying to get you to go to sleep or stay asleep. And then you're going to have some side effects. Maybe you feel a little groggy in the morning. Maybe you're someone who has taken Zolpidem, which is noted for amnesia, right? And you read these news stories about, somebody took a Zolpidem on their flight to Japan, and they woke up, and next thing you know, they're dancing in the aisles and having some reportable misdeed that really was the caused by the medication. So I think it's not one size fits all, but we do know that there is a standard of care for insomnia that's better than medications for most people. It lasts longer, it's more effective, and essentially it's a tool that most people could easily implement.
You've got me now. So it's better, it lasts longer, and it's easy to implement. What are you referring to?
Well, maybe when you read that back to me, it's not always easy to implement, but it's easily accessible for a lot of people. The actual therapy is called cognitive behavioral therapy for insomnia. And cognitive behavioral therapy, and I'm going to sort of stray outside of my lane here a little bit, but that is a tool used by a psychologist in the field. And you can treat a lot of things with CBT. And this is a specific format that is used to treat insomnia, to really try to sort of peel back the layers of the onion to get you back to that core physiologic sleep, and try to eliminate some of the distractionary behaviors that arise around sleep when you've suffered for 5, 10, 20 years in some cases.
So take me through that piece of it. When I say like, hey, I sleep 5 hours a night. I'd like to be sleeping 7, gosh, ideally 8. Take me through that. How do you approach that?
How much sleep do you need as an individual? And this gets back to our early discussion and some of the disservice we do to patients. You know, we push this idea that you need 8 hours of sleep, 8 hours of sleep, 8 hours of sleep. But there is a natural distribution of the amount of sleep individuals need. And most adults fall within like a 6 to 8 hour range of optimal sleep. I think most of us know intrinsically what our need is. Like I sort of know that I'm about a 7.5 hour sleeper. So if you judge yourself against a standard, let's say an 8 hour standard, but you are that 6 hour sleeper, by definition, you might always walk around with a sense that I'm doing something wrong or I have a problem. But when you really dig deeper and you start to explore, well, how does that 6 hours of sleep make you feel? You might find that people feel great, right? They function fine. They're not having problems at work. It's just that they're sort of forever worried about this mismatch between what they've been told they need to get and what they do get. How many hours do you need of sleep? And there's no blood test for that. I think that's just your adult experience. You know, maybe for most of my adult life, I was an 8 hour sleeper and now I'm only getting 6 hours. Well, that's probably reflects a change. But if I was always a 6 hour sleeper, I'm a 6 hour sleeper and I don't need to worry myself and get all wrapped up in a bundle because I can't hit that 8 hour mark.
And what's your advice to the people? Let's say you're a 6 hour sleeper, and you're spending a bunch of time in bed, which is what I hear people talk about, right? So they're like, hey, I should be an 8 hour sleeper. I'm only sleeping 6 hours. Therefore, I'm going to go get into bed at, 10 o'clock in the evening, and I'm going to sleep until 6 o'clock in the morning. But then they can't because they're a 6 hour sleeper, right? Which creates a bunch of anxiety and stress. How do you approach those folks?
Well, that's a key, what we call maladaptive behavior. And it's very understandable one, right? Like let's say you had a terrible night last night, or maybe all of last week. And so people start to say, well, okay, I'm going to sleep terribly. That's a given. There's no other reality. So provided that's the reality, I'm just going to put myself in bed for more time to try to get what I can get. And so what you see is you will see people, spend 8, 9, 10, 12 hours in bed because they're physically, emotionally, mentally exhausted, but they're not sleeping. But that just perpetuates this reality, which is you're not going to sleep that amount of time you're in bed. You can't do it.
Right.
But what you can do then is just experience this negative environment of I'm not sleeping. So if you spend 12 hours in bed and you sleep 2 hours and you're up for an hour and then you sleep for another 3 hours, then you're up for 2 hours, you might get plenty of sleep, but you may have a very terrible experience of that sleep.
Yeah, I remember with my wife, I think she's fine with me talking about it. She had this very problem where she was spending just too much time in bed. And so your advice to her, as I recall, was, okay, you actually should go to bed. Actually, as I recall, you started with the opposite. You said you should decide what time you're going to wake up in the morning. And I think she was like 7 o'clock in the morning and then work backwards from that. And so even if she was sleepy and it was getting to 10 o'clock, you had her stay up until 11 o'clock working from that 7 o'clock wake up and staying awake in the evening, she was able to, land the jumbo jet quietly, get into bed, be tired, sleep her amount of sleep, and then wake up at the same time. Is that, when you're talking about cognitive behavioral therapy, is that in some way an expression of CBT?
It's one of the key pillars, really. And that is what we call sleep restriction therapy. And what sleep restriction therapy utilizes is, let's just say, controlled sleep deprivation to internally allow you to build up a level of sleepiness that is then more likely to result in sleep, right? So if you go to bed and you're in bed for that 12 hours, you don't have that requisite level of sleepiness in your brain to maybe put you to sleep or keep you asleep. So we want to try to concentrate and focus that natural brain chemistry at the right time to get you the best sleep. But it really touches on one of the interesting observations I've heard many experts talk about, which is, your sleep really starts when you wake up. But the experience of sleep, for most people, myself included, but when you think about insomniacs, they focus really intensely on when they go to bed. I can't fall asleep. I'm not going to fall asleep. It's almost like a predetermined failure that they exist in. But if we can flip the script a little bit and really focus on what time works for you to be starting your day. So let's put that anchor in the ground, or the flag, and plant the flag in the ground and say, this is where we're starting. All right. We can then work backwards. And so what you would typically do with sleep restriction therapy is you'd agree upon a wake up time, and then you would agree upon a certain amount of sleep restriction. Maybe not extreme, but let's say we're only going to give you 6 hours in bed. So, you could do a simple math and you'd say, okay, well, I'd like to wake up at 6 a.m. Well, that means your bedtime is going to be midnight. This isn't a permanent state of being, but this is a short-term approach to try to restore that natural sleepiness. And it's very simple, but very powerful. It really requires people to give up all those maladaptive behaviors that they've really clung to over the years. There's no going to bed at 7 p.m., 8 p.m. because you're exhausted. You got to stay active, stay busy, watch a movie, do something fun until midnight. And that's very, very difficult. It sounds easy, but it's difficult.
So the idea here is you're going to commit to a time, 12 o'clock at night. And what will happen is that you will naturally become tired. You will be, to a certain extent, craving sleep. But then you force yourself to wake up at 6 o'clock in the morning. Even if your instinct is to sleep longer because you may be tired, you're going to make yourself wake up at 6 o'clock in the morning, right, and then wash, rinse, repeat. Do you pull that back and then move that to, like, I'm going to go to bed at 11 o'clock, and now you're going to try to, shoot for 7 hours of sleep? Mm-hmm. Is that the natural progression?
Exactly. Yeah. It really hinges on a thing that we call sleep efficiency, which is the percentage of time you're in bed, you're asleep. And for most adults without insomnia, you're looking at sleep efficiency of 85, maybe 90%. And so what you would do with that 6 hour window with that person is you would counsel them about when can you liberalize this? When can you go to bed 30 minutes earlier? And that gets to that, rinse, repeat type of cycle. And so now you do it at 6.5 hours and then at 7. And usually that person will start to find when they extend their sleep, let's say to 8 or 9 hours, it might be too much. And their sleep efficiency will reduce because they'll be spending more time awake in bed. But it is very counterintuitive. And if it's sort of like the 1-2 punch. You're going to tell an insomniac to stay up later and get up earlier. And sometimes that's a bridge too far, right? They just can't do it. And they can't make it through that first week or so. So it takes a lot of hand-holding, trust building, follow-up, things that aren't always so easy in modern healthcare. But people have actually reduced this to these core components. And so you don't necessarily always need to see a behavioral psychologist to do this. You could implement stimulus control, sleep restriction, and use that in a way that might get you right back where you need to be.
what about the people who do not have access to someone who is expert in CBT or who does not have access to a sleep specialist? Take me home here. Like, what is the main message that you want to communicate for those people still suffering from insomnia?
The number one main message is one of hope, right? So you have to know and you have to trust that it can be better. But to support that, there are things you can do. And so in my mind, probably the key trifecta to success, and these are things you could implement tomorrow if you're willing to, is really to set a wake-up time and stick to it. And make that wake-up time the time that works best for you, whether you're working or going to school, and try to keep that consistent on a daily basis. Number two is, if you can, is couple that wake-up time with light exposure. Outdoor sunlight is optimal for resynchronizing the brain, synchronizing your circadian rhythms, and setting you up for the best alertness during the day, which will then pay off the next night. And then the third thing is exercise. And pretty much every study at this point seems to support this idea, maybe a little bit common sense, but that exercise is really good for your sleep. My bias is that if you could do that exercise in the morning, even better. I wouldn't avoid exercise in the afternoon or the evening, but know that evening exercise sometimes can be a little stimulating. So in those people, you might want to try to take that exercise away as far away from your bedtime as possible, because you're just physically activated, which really isn't conducive to falling asleep. So those three pillars are really, that those can get you a long way. Sometimes they're just hard to stick to.
The thing that came to my mind immediately was, okay, so get up tomorrow, 7 a.m., 6 a.m., choose the time, whatever works for you, and stick to it. Go for a walk, right? So you're getting exercise. You could do more than that, but you could simply go for a walk. And the very fact that you're doing that outside is the light exposure piece. Right. And you've essentially been able to arrive at, a place where to start tomorrow morning.
Yeah. It's a habit, right? You could build that habit, and you essentially hit 3 birds with 1 stone if you can do that successfully, and then you move on with your day. Now, your first day, your first week may not be perfect with that, but I can guarantee that if you stick with that, you're going to have increasingly better nights of sleep and better experience with your sleep.
All right, John, we're at the point where I do something called sharing beauty. And I called you about an hour before we recorded this and said, hey, do you have anything to share beauty? Which is completely unfair for me to have done. But the good news is that a very good friend and fan of the show, Lauda, sent me a video, and it's of a little kid who's having a temper tantrum. And the father just makes sure that she's safe, but doesn't give in to the tantrum. And this really resonated for me because I remember, being sort of traumatized by the tantrum and then realized that I just had to let it go. Even if we were in a public place where it was even embarrassing, the kid will burn out on it. And essentially that's where this video goes. And so that'll be our sharing beauty for today. And John, next time we're going to talk about snoring and everything that sort of rolls up into snoring, like sleep apnea, among other sleep disorders. That'll be for next time. Thank you so much for joining me this time. You were great.
Thanks, Kevin.
And that's our show for today. The best way to support the show is to like and subscribe. This show was produced by Batsheva Gez and me. Until next time, be well. This show's content represents my personal opinions. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and does not create a physician-patient relationship with me. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition or your general health.